Mornings where your joints feel less like smoothly oiled machinery and, well, more like rusted grinding gears.
Oh, absolutely.
Or maybe you've experienced that sharp, instantaneous pop of a ligament tearing, knowing in that millisecond that the scaffolding holding you upright it's just temporarily failed.
Yeah, that's a feeling you don't forget.
Whether it's the debilitating stiffness of a chronic systemic condition that dictates how you start your day, or that tingling electric shock of a compressed nerve shooting down your limb, the musculoskeletal system is absolutely central to life. This material is vast, it's dense, and frankly, it can be overwhelming. We're covering acute trauma, mysterious tumors, urgent infections, and these complex autoimmune battles.
That's precisely why we're here. For this deep dive, we are taking a really targeted approach to this dense subject. We are not interested in rote memorization. We're interested in achieving true, rapid understanding. We aim to unlock the fundamental logic for you. Understanding the why behind the classic clinical presentation, the how behind the definitive diagnostic criteria, and crucially, the so what the pathway to immediate effective treatment. We want to move beyond the flashcard definition and into the clinical decision space.
That deep clinical logic is what our listener, the learner, is here for. We're going to spend time digging into those nuances, breaking down those detailed tables, understanding those tricky classification systems, and delivering those critical clinical aha moments. We have a lot of ground to cover, literally mapping the body from the clavicle down to the calcaneus.
Let's do it.
Okay, let's unpack this dense material and start our journey with the trauma that affects the whole body. We begin our anatomical progression in the upper extremity with one of the most common acute injuries, the clavicle fracture.
Oh.
This usually occurs after a fall onto the shoulder. It seems straightforward, but the presentation it's a powerful lesson in opposing muscle forces.
It truly is a perfect anatomical demonstration. When the clavicle, that S-shaped bone connecting the trunk to the shoulder fractures, the fragments are pulled in completely opposing directions.
Okay.
The key insight is understanding which muscle pulls which fragment. The proximal fragment, so the piece closer to your sternum, is pulled superiorly and posteriorly by the powerful upward vector of the sternocleidomastoid muscle.
So that's the big muscle in your neck. It's basically winning a tug of war against gravity and everything else. It just yanks that piece up.
It yanks it right up.
Yeah.
Exactly. And that's what creates that visible, palpable bump you can often see and feel. Conversely, the distal fragment, the piece attached to the shoulder, is dragged inferiorly. It's depressed and medially.
It's pulling it down.
This depression is caused by two things: the simple weight of the arm and the downward pull of the pectoralis major muscle.
So you get this dramatic deformity.
You do. And clinically, you must assess for skin tenting. That's where the sharp bone fragment pushes right up against the skin.
Why is that so critical?
Because that significantly increases the risk of the fracture becoming an open fracture. And an open fracture is an immediate surgical emergency.
Given how dramatic these can look, why is non-operative management, just a simple sling, still the standard of care for most of these midshaft fractures?
Because the midshaft has an excellent blood supply, the fragments usually heal quite well if they're not too displaced. So we reserve surgery, open reduction, and internal fixation, or RF, for very specific criteria.
Like the skin tenting?
Like the skin tenting, or if it's already an open fracture. But also severe displacement, often defined as greater than 2 centimeters, or if there's significant shortening of the bone, which can affect shoulder mechanics down the line.
And the most urgent reason.
And of course, any sign of neurovascular compromise. If the jagged ends of the bone threaten the brachial plexus or the subclavian vessels, that mandates immediate operative intervention, no question.
Moving just laterally, we hit the shoulder joint, which has the highest range of motion, and that makes it highly susceptible to dislocation. Anterior dislocations are the vast majority, something like 95% of cases?
That's right, 95%.
How do they present?
An anterior dislocation typically occurs when the arm is forced into abduction and external rotation. So think of a quarterback throwing a football. The patient presents holding the arm in that exact same position, slightly abducted and externally rotated. The humeral head pops out anteriorly, and you can often feel it. It's palpable beneath the coracoid process.
And there's a critical nerve at risk here.
Yes. The critical diagnostic high-yield point here, which you must assess immediately, is the high risk of injury to the axillary nerve.
That nerve wraps right around the surgical neck of the humerus, putting it directly in the line of fire.
It's in the perfect spot to get stretched or damaged. You assess the axillary nerve by checking motor function, which is the ability to abduct the arm.
The deltoid muscle?
The deltoid, yes. And sensory function. Specifically, you check for decreased sensation over the deltoid, which is the classic regimental badge area.
Okay, now the tricky one is the posterior dislocation. It's rare, only about 5% of cases, and the source material says it's frequently missed on initial x-rays.
It is. It's very easy to miss on a standard AP view.
So why is it so important to know about?
Posterior dislocations are characterized by the arm being held in adduction and internal rotation. They just don't look as deformed as anterior dislocations, which is a big reason why they're missed. But the mechanism is the key.
Okay.
They are typically seen after powerful, uncontrolled muscle contractions. The classic examples are a grand mal seizure or an electrocution injury.
So if a patient has either of those events and presents with shoulder pain,
You must specifically request an axillary lateral or a modified view, like a Y view, to visualize the posterior displacement. You can't rely on the front-on view. Treatment is always prompt reduction to minimize damage to the articular cartilage, followed by stabilization.
next, speaking of the shoulder, we need to distinguish an acute rotator cuff tear from, say, chronic tendinopathy, or even from systemic causes of weakness.
Right. An acute tear presents with sudden pain and immediate noticeable weakness, particularly when attempting abduction and external rotation. The most commonly involved tendon is the supraspinatus.
And how do you confirm it?
Diagnosis is confirmed by MRI, especially if you suspect a full-thickness tear. The source material is clear that significant shoulder stiffness, coupled with that pain and weakness, helps you distinguish this from a systemic myositis like dermatomyositis, where the weakness is often more isolated to just weakness, and it's usually bilateral.
And the management. Does every tear require surgery?
No, not at all. For partial tears or chronic tendinosis, the focus is conservative. Rest, NSIs, and aggressive active range of motion exercises guided by physical therapy. The goal is to maximize the function of the remaining healthy tendons.
When you operate.
Surgery is generally reserved for full-thickness tears in younger, active patients, or when conservative management fails after several months and the patient still has significant functional deficits.
Okay. Descending the arm, we get to the humerus. We establish that mid-shaft fractures put the radial nerve at risk, but the forearm structure, that's what sets up this unique nightstick trio of injuries.
The forearm structure is fascinating. It's a great example of a closed ring system. You have two bones, the radius and the ulna, and they're joined by this strong interosseous membrane. They function together.
Meaning if one part breaks, another part has to give way.
Exactly. If you fracture one bone and it displaces, the forces are transmitted up or down that interosseous membrane, and the adjacent joint must dislocate to compensate for the lost stability. You can't have a displaced fracture of one bone without an injury to the joint at the other end.
Let's start with the simplest, the nightstick fracture.
That's a pure ulnar shaft fracture. It's often from a direct blow, like someone raising their forearm to defend themselves, hence the name nightstick. If it's isolated and non-displaced, conservative treatment with a cast is perfectly appropriate.
Then we get the paired injuries where the dislocation is the critical component. Let's do the Monteggia fracture.
Monteggia involves a diaphyseal fracture of the ulna with an associated subluxation or dislocation of the radial head at the elbow.
So it's an ulnar fracture, but the real problem is up at the elbow.
That's the part that gets missed. The treatment is complex. You must perform an open reduction and internal fixation, the ORIF, of the ulnar shaft first. By restoring the length and stability of the ulna, you often allow the radial head to be closed, reduced back into its proper place.
And the Galeazzi fracture is the opposite configuration.
Galeazzi is the reverse pattern. It's a diaphyseal fracture of the radius combined with the dislocation of the distal radial ulnar joint, or the DRUJ, down at the wrist.
So a radius fracture with a wrist dislocation.
Exactly. And just like Monteggia, you must ORIF the fractured radius first to restore the forearm axis. Once that radial length is corrected, the DRUJ dislocation can usually be reduced and stabilized with casting or sometimes temporary pins.
Is there a good way to keep those straight?
The high-yield way to remember this pairing is to think. Monteggia is ulna fracture, radial head dislocation, that's proximal. Galeazzi is radius fracture, distal joint dislocation.
Moving down to the wrist, we hit the two classic fractures associated with a fous to fall onto an outstretched hand. First, the Colles fracture.
The Colles fracture results from a fouche with the wrist in dorsiflexion, so bent backward. This causes the distal fragment of the radius to displace dorsally, leading to the classic dinner fork deformity.
You can actually see the shape of a fork in the wrist.
You can. It's the most common distal radius fracture, highly prevalent in older adults because of osteoporosis, but you see it in kids too.
And the treatment is primarily closed.
Yes, usually a closed reduction and a short arm cast. We only move to surgery if the fracture is severely comminuted, meaning in many pieces intra-articular, or if it's just irreducible with closed methods.
The other key wrist injury involves the scaphoid, and this is where the anatomical constraint dictates a major risk, a vascular necrosis or AVN.
This is a time-sensitive diagnosis that you cannot miss. The scaphoid is the most frequently fractured carpal bone. After a FUSH, the patient presents with pain and tenderness, specifically in the anatomical snuff box.
That's the little depression at the base of the thumb.
Correct. And here is the critical pitfall. Initial x-rays may be completely normal. They can be negative for up to 2 weeks because the fracture line might be a hairline crack or just hidden by the initial swelling.
So if the exam is positive, if the snuff box hurts when you press on it, you treat it even if the x-ray is negative.
Absolutely, 100%. If the snuff box is tender, you treat it as a fracture. You immobilize it in a thumb spica cast.
Why the urgency?
The reason for this urgency is the scaphoid's retrograde blood supply. The blood enters the bone at its distal pole and flows backward, or retrograde, to supply the proximal part. A fracture right in the waist of the scaphoid disrupts this supply, virtually guaranteeing AVN of that proximal fragment if it's not properly immobilized.
And that leads to
Non-union, chronic pain, and arthritis. A delayed diagnosis is a major cause of permanent disability in the wrist.
Let's quickly wrap up the hand with 2 focused diagnoses. The boxer's fracture and decurvane tenosynovitis.
Boxer's fracture is pretty straightforward. It's a fracture of the neck of the 5th metacarpal, typically from punching a wall or another rigid object. Closed reduction is standard unless the angulation is severe.
And decurvanes.
Decurvanes is an overuse syndrome. It's a tenosynovitis, so inflammation of the tendon sheath, involving the 2 tendons of the thumb, the abductor pollicis longus and extensor pollicis brevis, as they pass through a tight sheath at the radial wrist.
It's associated with new parents holding infants or, chronic overuse of handheld devices, the texting thumb, and the diagnostic shortcut is the Finkelstein test.
Correct. The Finkelstein test is very high yield. You ask the patient to flex their thumb across their palm, make a fist over it, and then put the wrist into forceful ulnar deviation.
So bending the wrist away from the thumb.
Exactly. If that maneuver causes exquisite, sharp pain over the radial styloid, the test is positive. Treatment begins with immobilization in a thumb spica splint, NSAIDs, and steroid injections if those conservative measures fail. Moving from specific injuries, let's look at the systems that govern our initial decisions, starting with the Ottawa ankle rules. This is a perfect example of a high-yield clinical tool designed to improve resource utilization.
These rules guide whether an X-ray is necessary for acute ankle or midfoot trauma. From a public health standpoint, this reduces unnecessary radiation exposure and cost, but from a patient care standpoint, how does it balance the risk of missing something?
It achieves a crucial balance by having nearly 100% sensitivity for clinically significant fractures, which means if the rules are negative, you can be very confident you haven't missed a fracture.
So what are the rules?
The rule states that you only need an X-ray if the patient cannot walk 4 weight-bearing steps, both immediately after the injury and in the clinic OR if they have specific point tenderness in critical bony areas.
Okay, detail those critical tender points for us.
For the ankle, X-rays are required if there is point tenderness on palpation of the posterior edge or the tip of the medial or lateral malleolus. Those are the 2 big bony prominences of the ankle.
And for the foot.
For the foot, X-rays are required if there's tenderness at the midfoot over the navicular bone or the proximal 5th metatarsal. That's the bone leading to the pinky toe, which is susceptible to some tricky fractures like a Jones fracture.
So if the patient can walk 4 steps and there's no specific bony tenderness in those 4 spots, a fracture is extremely unlikely.
Exactly. And you can begin conservative management for a sprain safely.
Switching to pediatric trauma, we have the crucial Salter-Harris pediatric fracture classification for growth plate injuries. We have to understand this because it predicts the risk of long-term growth complications, and we use the mnemonic SALT-TR.
This classification is absolutely critical because the physis, or the growth plate, is the weakest part of a child's long bone. It's weaker than the ligaments. So damage here can lead to growth arrest or limb length discrepancies down the road.
And the mnemonic SALT-TR classifies the fracture line relative to the physis, P, the metaphysis, M, which is above the physis, and the epiphysis, E, below the physis.
Correct. Let's walk through it.
Okay, let's define the 5 types.
S stands for slipped, type 1. The fracture line goes straight through the physis. It's slipped. This is a good prognosis if it's reduced properly.
Okay, S is slipped.
A is for above, type 2. The fracture goes through the physis and then extends above into the metaphysis. This is actually the most common type, and it generally has a good prognosis as well.
Oh.
L is for lower, type 3. The fracture goes through the physis and extends lower into the epiphysis, and that means it enters the joint space. This is more concerning because it's an intra-articular fracture. T is for through, type 4. This is a serous fracture that goes through all three structures: the metaphysis, the physis, and the epiphysis. It crosses the growth plate and the joint.
And finally, R for rammed crushed, type V. This one is the worst.
Type V is the most dreaded in terms of prognosis. The R stands for rammed, ruined, or crushed. It's an axial load injury, a compression injury, that obliterates the physis.
So it's not a crack, it's a crush.
It's a crush. And because the blood supply is severely damaged and the cartilage cells are crushed, type V frequently results in growth arrest. The bone just stops growing prematurely. This requires very careful monitoring and often future surgical intervention to correct limb length.
That distinction between the involvement of the growth plate and the risk of that growth arrest is the core high-yield concept there. Switching back to the knee, we have the famous unhappy triad. What specific mechanism causes this injury pattern?
The unhappy triad, or sometimes called the terrible triad, results from a substantial valgus force. That's an outward-directed force applied to a planted foot or a fixed lower leg. You see it all the time in contact sports like football or skiing.
And the combination of injuries is?
It's the anterior cruciate ligament, ACL tear, the medial collateral ligament, MCL tear, and, crucially, a tear of the medial meniscus.
Why the medial meniscus specifically? Is it just because of its location?
It's anatomical tethering. It's a great question. The medial meniscus is physically attached to the deep fibers of the MCL. So when the MCL tears from that severe valgus stress, it often drags the medial meniscus with it, leading to that common combination. This is a severe injury that often requires surgical reconstruction of the ACL and MCL and repair or removal of the damaged meniscus.
Now let's trace the pathways of peripheral nerve damage. This is all about connecting the anatomical location of vulnerability to the specific motor and sensory deficits. Knowing these patterns is essential for localizing damage after trauma or surgery.
Absolutely. We'll start with the most often iatrogenically injured nerve, the long thoracic nerve.
Iatrogenic meaning caused by medical procedure.
Exactly. Its function is high yield because of the visible presentation of damage. The nerve innervates the serratus anterior muscle.
And that's the muscle that holds the scapula, the shoulder blade, against the chest wall during movement.
Yes. So if it's injured, the patient loses the ability to abduct the arm fully above 90 degrees, but the classic clinical finding is the unmistakable winging scapula. The medial border of the scapula literally lifts off the thoracic cage when the patient pushes against a wall.
And what causes this?
The cause is often surgery, axillary lymphadenectomy for breast cancer, a mastectomy, or sometimes chest tube placement, or just direct trauma to the lateral chest wall. This is a motor-only nerve, so there is no specific sensory deficit.
Next, the radial nerve, famous for its vulnerability in midshaft humerus fractures.
The radial nerve runs in the spiral groove of the humerus, making it highly exposed to fracture displacement. Damage leads to the complete loss of wrist, finger, and thumb extension,
Which results in?
the classic wrist drop. This is also the nerve compressed in Saturday night palsy or a honeymoon palsy, where the arm is compressed against a hard object for prolonged periods. Sensory loss is typically over the posterior forearm and the dorsal surface of the hand.
The median nerve is critical at the elbow and the wrist. How does injury present proximally versus distally?
Proximally, an injury-like one caused by a supracondylar fracture of the humerus in a child affects forearm pronation, wrist flexion, and the ability to flex the first 3 digits.
So if the patient tries to make a fist,
They can't flex the thumb, index, and middle fingers. This is the hand of benediction sign. Crucially, the functional test for a proximal injury is the inability to make the OK sign.
and distally at the wrist, that's carpal tunnel.
Exactly. That's carpal tunnel syndrome, where the median nerve is compressed. Here, the sensory symptoms are dominant. Numbness and tingling in the first 3.5 digits on the palmar surface, often waking the patient at night.
And it's been going on for a long time.
If it's long-standing, you get the thunar eminence atrophy. That's the muscle pad at the base of the thumb. It affects opposition.
Let's move to the ulnar nerve.
The ulnar nerve is often injured at the elbow, in the cubital tunnel, the funny bone, or at the wrist in the Guillain Canal, often due to a fracture of the hook of the hemate bone.
And the deficit.
Its primary motor deficit is loss of intrinsic hand muscle function, particularly the interosseous, which leads to the inability to abduct and adduct the fingers. The classic presentation is a weak claw hand affecting the fourth and fifth digits. Sensory loss is over the palmar and dorsal surfaces of the last 1.5 fingers.
Finally, for the upper limb, the axillary nerve.
This nerve is responsible for the first 15 degrees of arm abduction via the deltoid and teres minor muscles. We look for decreased sensation over the deltoid, that specific regimental badge area, after trauma like an anterior shoulder dislocation or a surgical neck fracture of the humerus.
Pivoting to the lower limb, let's address the nerve responsible for the steppage gait.
That is the common peroneal nerve, which wraps very superficially around the neck of the fibula.
Making it very easy to damage.
Very easy. It controls dorsiflexion and eversion of the foot. Damage, often from a knee dislocation or a traumatic blow to the side of the leg, results in foot drop. To compensate, the patient has to lift their knee high to avoid dragging their toe. That's the steppage gait.
The superior gluteal nerve loss manifests as the classic Trendelenburg sign.
If the superior gluteal nerve is damaged, the gluteus medius and minimus, the primary hip abductors, are weakened. When the patient stands on the affected leg, the pelvis drops toward the unaffected side.
So the opposite side drops.
The opposite side drops. That drop is the positive Trendelenburg sign, and it indicates weakness of the hip abductors on the standing side.
And the purely sensory nerve causing neuralgia paresthetica.
That's the lateral femoral cutaneous nerve. It provides sensation to the lateral thigh. Compression, often from tight belts, tight clothing, or sometimes related to obesity or pregnancy, causes numbness and tingling over that lateral thigh. That's neuralgia paresthetica. Now we address a condition that is extremely challenging clinically and often poorly understood. Complex regional pain syndrome, or CRPS. This syndrome involves pain that is wildly disproportionate to the inciting injury, characterized by loss of function and striking autonomic dysfunction.
The clinical presentation is not explained by a specific nerve lesion, which is part of the diagnostic difficulty. And the pathology progresses through 3 distinct phases.
Correct. Phase 1 is the acute phase. This phase usually follows some kind of trauma, a fracture, a crush injury, even a surgery. It is characterized by acute, burning pain, swelling, or edema, and often increased warmth and sensitivity or hyperesthesia in the limb.
In phase 2.
Phase 2 is the dystrophic phase. The edema progresses, muscle wasting begins, and the skin changes significantly. It becomes cool, shiny, and tight. Radiographs may start showing patchy demineralization of the bone at this point.
And the final phase, which reflects permanent changes.
Phase 3 is the atrophic phase. This is characterized by irreversible changes. Marked joint contractures, severely limited movement, and severe visible demineralization of the bone on imaging. The limb often appears cold, atrophic, and non-functional.
Since pain is subjective, what objective criteria do you look for to support the diagnosis of CRPS?
The diagnosis relies on what are called the Budapest criteria, which require objective evidence of autonomic and sensory changes. We look for allodynia, which is pain to a non-painful stimulus like a light touch.
So even bed sheets can hurt.
Exactly. We also look for changes in skin temperature or color, abnormal sweating, either increased or decreased, and changes in hair growth or nail growth. All of these have to be localized to the affected limb and disproportionate to the initial injury.
And the treatment reflects the complexity, often targeting the sympathetic nervous system.
The foundation is physical and occupational therapy to maintain function. For the pain, we use a multimodal approach. NSAIDs, antidepressants like TCAs, and anticonvulsants like gabapentin or pregabalin for the neuropathic component.
And the more specialized intervention.
The specialized intervention is the chemical sympathetic blockade. This involves injecting an anesthetic near the sympathetic ganglia. By blocking the aberrant sympathetic nerve signals, this can dramatically reduce the pain and restore normal vascular tone, which is often crucial for breaking the pain cycle in CRPS.
We shift now to bone pathology, starting with the most common primary malignant bone tumor, osteosarcoma. If a teenager presents with pain worsening at night, fevers, and weight loss, what is the classic presentation and location?
Osteosarcoma most commonly occurs in the metaphyses of the long bones, especially around the knee, so the distal femur or the proximal tibia. This is the area of maximal bone growth in adolescence.
And the pain is a key feature.
The pain is usually progressive, deep, and often wakes the patient at night, which is a big red flag for malignancy.
The imaging findings are key to differentiating this. What does the X-ray show that screams osteosarcoma?
The classic X-ray findings are the Codman triangle, which is a triangular shadow under the elevated periosteum where the tumor is pushing it outward, or the sunburst pattern where you see bone spicules radiating outward from the tumor mass. This aggressive periosteal reaction reflects the rapid, destructive nature of the tumor.
What's the diagnostic pathway?
X-ray is the best initial test. Staging and evaluation of soft tissue spread will require an MRI or a CT. But the definitive diagnosis, the most accurate test, is the bone biopsy, which will confirm malignant osteoid production. Treatment is aggressive, often involving neoadjuvant chemotherapy, followed by wide surgical resection limb-sparing surgery, if possible, and then sometimes more chemotherapy afterward.
Now, let's quickly differentiate the high-yield benign bone tumors based on their imaging characteristics and location.
We can distinguish them by their patterns. An enchondroma is a lytic lesion, commonly found in the small bones of the hand or foot. A giant cell tumor is typically found near the end of long bones, in the epiphyses, and has the classic soap bubble appearance on X-ray.
And that one has a specific association.
Right. It's important to note its association with Paget disease and the specific use of denosumab for treatment.
And the two that relate to bone tissue structure, osteochondroma and osteoid osteoma.
Osteochondroma is the most common benign tumor overall. It's an outgrowth of the growth plate. It projects out from the bone like a little mushroom.
And the osteoid osteoma.
Osteoid osteoma is a small tumor, typically less than 2 centimeters, which classically causes pain that is dramatically relieved by NSAIDs like aspirin or ibuprofen.
Why do NSAIDs work so well for an osteoid osteoma?
It's fascinating. The tumor produces large amounts of prostaglandins, specifically PGE2, which mediate the pain. NSAIDs inhibit the cyclooxygenase enzyme that synthesizes these prostaglandins, leading to prompt, almost diagnostic pain relief. This response to NSAIDs can actually be a clue for the diagnosis.
What about Ewing sarcoma, the other major adolescent malignancy?
Ewing sarcoma is highly malignant, often affecting the long bones or the pelvis. On X-ray, it presents as large, permeative lesions with the classic onion skin appearance.
What causes that onion skin look?
It's a layered, concentric periosteal reaction that reflects intermittent bursts of tumor growth. Treatment also involves aggressive surgery and chemotherapy, but unlike osteosarcoma, Ewing sarcoma is uniquely sensitive to radiation therapy, which is often a key part of its management plan.
Moving from cancerous pathology to infectious emergencies, we must discuss septic arthritis, the red-hot joint. This is a surgical and medical emergency.
It is indeed. Septic arthritis is an infection within the joint space. It's most often monoarticular, involving one joint, typically the knee. The patient presents systemically ill, febrile, with an acutely painful, warm, swollen, and immobile joint. The critical diagnostic step is analysis of the synovial fluid.
This is where we need to spend time differentiating the fluid profiles. The numbers are the diagnostic shortcut.
They absolutely are. So let's compare the categories. A non-inflammatory joint, like in osteoarthritis, has a WBC count generally below 2,000 cells per millimeter cubed, and the fluid is clear.
Okay.
An inflammatory joint, like in rheumatoid arthritis or gout, sees that WBC count rise significantly, somewhere between 2,000 and 50,000.
But the septic joint fluid profile is distinct and mandates immediate action.
Septic fluid is characterized by a WBC count greater than 50,000 cells, often exceeding 100,000. The fluid is purulent. It looks like pus, yellow-green, and turbid. But the most high-yield metabolic distinction is the glucose level.
Why does the glucose drop so dramatically in septic fluid?
Because the high number of rapidly reproducing bacteria within that closed joint space are consuming all the available glucose for their own metabolism.
So they're eating the sugar.
They're eating the sugar. Therefore, a synovial fluid glucose level less than 25 milligrams per deciliter, or less than 50% of the serum glucose, is a powerful indicator of a bacterial infection.
We must also link specific etiologies to their risk factors to guide empiric treatment.
Right. Staphylococcus aureus is the most common culprit across all age groups and in conditions like IV drug use. However, if the patient is young and sexually active, you must immediately suspect Neisseria gonorrhea, which can present as a migratory polyarthralgia, tenosynovitis, or a purulent monoarthritis.
The classic sickle cell link.
We must remember the link between sickle cell disease and salmonella as a cause for both septic arthritis and osteomyelitis.
What is the emergent treatment approach?
This is a surgical emergency because the highly inflammatory environment and the elevated pressure within the joint rapidly destroy the articular cartilage. The treatment is emergent joint drainage and surgical debridement. Antibiotics, empiric coverage like vancomycin plus ceftriaxone are started immediately after the fluid is aspirated, pending culture results.
Now let's consider infection of the bone itself, osteomyelitis. This is often harder to diagnose early because the infection is deep-seated.
Osteomyelitis occurs either through direct inoculation from a puncture wound, an open fracture, or a diabetic foot ulcer, or via hematogenous spread, which is infection carried through the bloodstream.
Where do you see that?
It's common in the vertebrae of FMGE drug users or in the long bones of children. The choice of empiric antibiotics is heavily guided by the risk factor and the likely pathogen.
Detail that pathogen risk factor link for us.
S. aureus is the most common overall. But if it's a puncture wound through a shoe, especially in a child, we must cover Pseudomonas aeruginosa. In chronic cases, like those associated with severe diabetes or peripheral vascular disease, the infection is often polymicrobial, a combination of S. aureus, Pseudomonas, anaerobes, and others.
X-rays are usually the initial test, but you mentioned they can be deceivingly normal.
Yes. X-rays often don't show clear signs of bone destruction or periosteal elevation for 10 to 14 days after the infection begins. Therefore, MRI is the preferred test for high suspicion cases because it can visualize early soft tissue edema and bone marrow changes.
But what's the definitive test?
The definitive diagnosis and the most accurate test remains the bone biopsy and aspiration to obtain a culture for targeted treatment. Labs will show elevated inflammatory markers like ESR and CRP.
And the treatment requires both structure and long-term pharmacologic repair.
Necrotic infected bone acts as a nidus for persistent infection, so surgical debridement of that dead bone is required. This must be followed by a prolonged, often 4 to 6 week course of antibiotics, tailored to the culture results, such as vancomycin for suspected MRSA.
We move into the chronic conditions, and this comparison, osteoarthritis versus rheumatoid arthritis, is perhaps the highest yield differential in rheumatology. It defines whether the patient is suffering from a mechanical failure or an autoimmune assault.
It's a fundamental distinction.
Let's unpack the variables that clearly define each disease.
The contrast begins with the patient history. Osteoarthritis, or OA, is the classic wear and tear disease. It primarily affects older patients, has a slow, insidious onset, and the pain worsens with activity and use and improves with rest. Morning stiffness is usually present, but it's brief. It lasts less than 30 minutes.
And the pattern of joint involvement is crucial for differentiation.
OA is typically asymmetric and preferentially affects weight-bearing joints, hips, knees, spine, and specific joints in the hand. The distal interphalangeal joints, the DIPs, and the proximal interphalangeal joints, the PITs, as well as the base of the thumb, the CMC joint.
And the bony enlargements we see.
Those are the Heberden nodes at the DIPs and the Bouchard nodes at the PIPs.
In terms of diagnostics, what confirms that this is a mechanical, non-inflammatory process?
Radiographically, we see joint space narrowing, subchondral sclerosis, and osteophytes or bone spurs. Crucially, if we aspirate the joint, the synovial fluid is non-inflammatory, with a WBC count under 2,000.
And treatment reflects that mechanical nature.
Exactly. It focuses on mechanics, physical therapy, weight reduction, and pain relief using NSAIDs. Intra-articular steroid injections offer temporary relief, but for end-stage destruction, the definitive treatment is joint replacement or arthroplasty.
Now let's sharply contrast that with rheumatoid arthritis, RA, a true systemic inflammatory disease.
RA affects a younger demographic, has a rapid onset over weeks to months, and the inflammatory pain is characterized by prolonged morning stiffness, lasting greater than 30 minutes, often an hour or more. And here's the key difference. The pain often improves with activity as the day progresses.
The joint pattern for RA is nearly the mirror image of OA.
It is. RA follows a classic symmetric distribution. It primarily targets the small joints of the wrist, the metacarpophalangeal joints, or MCPs, and the PIP joints. The distinguishing high-yield fact is that the DIP joints are usually spared in RA. That helps differentiate it from OA and psoriatic arthritis.
What's the underlying pathology?
The underlying pathophysiology is chronic inflammation of the synovium, which forms a destructive tissue called pannus that erodes cartilage and bone.
How do we confirm the diagnosis and its inflammatory nature?
Diagnosis requires specific clinical criteria, like a duration of more than 6 weeks and serology. While the rheumatoid factor, or RF, is useful, the anti-CCP antibody is much more specific for RA. Inflammatory markers like ESR and CRP are elevated, and the synovial fluid is inflammatory, with a WBC count between 2,000 and 50,000.
Treatment for RA is focused on stopping the underlying destruction.
Yes. The cornerstone of treatment is disease-modifying antihumatic drugs, or DMARDs. Methotrexate is the standard initial therapy. We also use hydroxychloroquine, sulfasalazine, and biologic agents like TNF inhibitors. Glucocorticoids are used only for acute flares or as a bridging therapy.
We must reinforce the critical warning regarding hydroxychloroquine.
It's vital. Hydroxychloroquine carries the risk of irreversible retinal toxicity, which mandates regular ophthalmologic screening to look for the characteristic bullseye appearance of retinal damage. This is a severe, often permanent side effect. Shifting to the axial skeleton, we have the spondyloarthropathies, a group of inflammatory conditions primarily affecting the spine and pelvis, all strongly associated with the genetic marker HLA-B27.
The prototype of this group is ankylosing spondylitis, or AS. What is the signature presentation that distinguishes its back pain from common mechanical back pain?
AS usually presents in young men, often starting in the sacroiliac joint, with chronic low back pain and stiffness. Unlike mechanical back pain, the AS pain is worse in the morning and with rest, but dramatically improves with exercise and activity. They lose spinal mobility, which we measure clinically with the Schober test.
And the X-ray findings illustrate the destructive fusion process.
The initial X-ray shows sacroilitis. Over time, the ligaments and outer layer of the intervertebral discs calcify, forming bony bridges called syndesmophytes. This leads to the dramatic appearance of the bamboo spine.
AS is associated with several serious non-articular complications.
The major ones are anterior uveitis, which is eye inflammation, cardiac issues like aortic insufficiency, and a strong co-occurrence with inflammatory bowel disease and psoriasis.
Next, reactive arthritis, RAOA, famous for following an infection outside the joint.
Reactive arthritis typically arises days or weeks after a preceding GI infection like Salmonella, Shigella, Yersinia, or a GU infection, most commonly Chlamydia trachomatis.
In the classic mnemonic for this syndrome.
The famous mnemonic, can't see conjunctivitis uveitis, can't pee arthritis, can't climb a tree, arthritis. The arthritis itself is usually an asymmetric oligoarthritis of the lower extremities and, like other spondyloarthropathies, often features enthesitis inflammation where tendons and ligaments insert into the bone, often manifesting as painful heel spurs. Now, the classic multi-system disease, systemic lupus erythematosus, or SLE. The diagnosis is heavily dependent on specific autoantibodies, which must be clearly differentiated.
Let's start with the best initial screen.
The ANA, or anti-nuclear antibody, is the best initial test. It is highly sensitive, meaning if it's negative, SLE is highly unlikely, but it is very nonspecific. Many other conditions can cause a positive ANA.
What are the two antibodies that lock in the SLE diagnosis?
The anti-dsDNA antibody and the anti-SM antibody are highly specific for SLE. Anti-dsDNA is clinically crucial because its titers are monitored to track disease activity, especially the severity of lupus nephritis or kidney inflammation.
We also need to be able to identify specific clinical subsets based on serology.
Right. Anti-cystone antibodies are the marker for drug-induced SLE, which is often triggered by medications like procainamide or hydralazine, and it typically spares the kidneys. Anti-Rho and anti-LA antibodies are associated with Sjogren's syndrome, and in pregnant patients, they carry a serious risk of causing neonatal SLE in the infant, specifically leading to congenital heart block.
The source material also ties in the highly confusing anti-phospholipid antibodies.
These antibodies, like lupus anticoagulant or anticardiolipin, are present in about 10% of SLE patients and define the antiphospholipid syndrome, or APS. APS causes hypercoagulability, resulting in arterial and venous thrombosis clots and recurrent unexplained spontaneous abortions.
And there's a classic lab finding associated with it.
Yes, a classic high-yield linkage is that APS antibodies can cause a false positive result on the VDR-RPR screening tests for syphilis.
Beyond the serology, how does SLE affect other systems, such as the heart?
SLE affects nearly every system. In the heart, it is notorious for causing Lipnin-Sachs endocarditis, which is characterized by sterile, non-infectious vegetations, usually on the mitral or aortic valves, and renal involvement, nephritis, is the leading cause of morbidity and requires aggressive management.
And the treatment ladder?
Mild disease like skin and joint pain is treated with NSAIDs and chronic control using hydroxychloroquine. Acute flares require systemic corticosteroids. Severe organ-threatening disease, particularly proliferative lupus nephritis, requires strong immunosuppression, such as mycophenolate mofetil or cyclophosphamide. Next, the inflammatory myopathies, polymyositis and dermatomyositis. These are diseases of muscle inflammation.
Both conditions share the same core presentation of muscle weakness.
The hallmark presentation is symmetric, proximal muscle weakness. Patients report difficulty performing tasks that rely on strong core and upper leg and arm muscles, difficulty climbing stairs, getting up from a low chair, or lifting objects over their head.
And dermatomyositis adds the skin findings.
Yes, dermatomyositis adds characteristic skin findings. The heliotrope rash, which is a purplish discoloration around the eyelids, and Gottron papules, which are violaceous, raised lesions over the knuckles and joints.
How do we differentiate this from other causes of weakness, like PMR?
The initial workup involves checking muscle enzymes. Creatine kinase, or CK, aldolase, and transaminases will be markedly elevated due to muscle destruction. This elevation differentiates it from PMR. The most accurate diagnostic test remains the muscle biopsy. We also look for specific antibodies, such as anti-Jo1. Treatment is typically high-dose corticosteroids.
Let's transition to systemic sclerosis, or scleroderma, a disease defined by chronic inflammation leading to widespread fibrosis and hardening. This is divided into the limited and diffuse forms.
The limited cutaneous form is often referred to as crest syndrome. The fibrosis is restricted to the face, neck, and areas distal to the elbows and knees. The crest mnemonic stands for calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias. The associated antibody is the anti-centromere antibody.
And the more aggressive, diffuse cutaneous form.
This form involves the torso and proximal limbs, and it rapidly progresses to serious internal organ involvement, including severe GI dysmotility, widespread pulmonary fibrosis, and the potentially fatal scleroderma renal crisis, which is acute renal failure. The associated antibody for the severe form is the anti-CL70 or anti-topoisomerase antibody.
Vasculitis syndromes are inflammatory diseases of blood vessels, often presenting with vague systemic and musculoskeletal symptoms. We'll focus on large vessel vasculitides, starting with the ophthalmologic emergency, giant cell arteritis, or GCA.
GCA, or temporal arteritis, affects medium and large vessels, primarily in the carotid system. The risk profile is specific. Patients must be over 50 years old, and it is more common in women.
What clinical signs should trigger immediate, urgent concern?
A new onset, usually unilateral headache, often accompanied by jaw claudication pain in the masseter muscles while chewing scalp tenderness, and systemic signs like fever and weight loss. The highest yield, most feared complication is irreversible blindness due to occlusion of the ophthalmic artery.
And that can present as?
Initially as transient visual loss, or amaurosis fugax.
The diagnostic pathway here is unique because treatment cannot wait for confirmation.
That's the key clinical mandate. The best initial test is the markedly elevated ESR, usually over 50, often over 100, and CRP. The definitive diagnosis is the temporal artery biopsy, showing granulomatous inflammation. However, the treatment immediate, high-dose systemic prednisone must be started based on clinical suspicion alone to prevent vision loss, even before the biopsy is performed.
Contrasting GCA, we have Takayasu arteritis.
Takayasu is also a large vessel vasculitis of the aorta and its main branches, but it affects a much younger demographic, typically Asian women under the age of 40. It causes chronic inflammation and narrowing of the vessels. The classic presentation is aortic claudication, and due to the narrowing, a differential blood pressure between the upper extremities or diminished peripheral pulses, hence its nickname, the pulseless disease. Diagnosis is confirmed via angiography.
And finally, Bisset syndrome, a distinct form of small to medium vessel vasculitis.
Bisset syndrome is characterized by a triad of symptoms: recurrent, painful oral ulcers, aphthous stomatitis, recurrent genital ulcers, and eye inflammation, or uveitis. It's an autoimmune condition often seen in individuals of Turkish or Middle Eastern descent, and thrombosis is a common complication.
Before leaving systemic conditions, we must clearly distinguish between these two syndromes, which both cause widespread stiffness but have completely different pathologies, one inflammatory, one non-inflammatory.
Polymyalgia rheumatica, or PMR, is the inflammatory one. It occurs in patients over 50 and presents with aching and profound stiffness in the shoulder and pelvic girdles, severely impacting daily function. The stiffness is classically worse in the morning.
And the crucial diagnostic criteria are based on inflammation markers and CK.
PMR is defined by a significantly elevated ESR and CRP, often exceeding 100. Crucially, the CK or creatine kinase is normal, confirming that the issue is not muscle destruction, like in myositis, but periarticular inflammation.
And the response to treatment is also diagnostic.
It is. Its diagnosis is often confirmed by its rapid, dramatic response to low-dose prednisone, around 10-20 milligrams per day. We must also remember that PMR is highly associated with giant cell arteritis.
Now, fibromyalgia, the chronic diffuse pain disorder.
Fibromyalgia causes chronic diffuse musculoskeletal pain and stiffness associated with systemic symptoms like severe fatigue, sleep disturbance, anxiety, and cognitive dysfunction, often called fibrofog. Patients present with multiple subjective tender points, not swollen joints, across all four quadrants and the axial skeleton.
What defines the diagnosis of fibromyalgia in the lab?
The diagnosis is clinical, based on the history of chronic pain and tenderness. The lab results, ESR, CRP, and CK, are all normal. This normal lab work is critical. It rules out inflammatory arthritis and myositis.
And treatment is very different.
Treatment is complex, focusing on multimodal therapy. Patient education, low-impact exercise, antidepressants, and anticonvulsants like gabapentin. The source material strongly emphasizes the avoidance of opioid narcotics.
Let's dive deeper into specific extremity syndromes, starting with the notorious adhesive capsulitis, or frozen shoulder. This condition often follows minor trauma or immobilization, making the shoulder painful and just locked down.
Adhesive capsulitis is inflammation and fibrosis leading to contraction of the glenohumeral joint capsule. It is common in middle-aged and older adults, and notably more prevalent in diabetics. The presentation is insidious, starting with pain and progressing to profound stiffness.
How do you clinically differentiate this from a rotator cuff tear or impingement?
The diagnostic hallmark is the global restriction of both active and passive range of motion. With a rotator cuff tear, the patient may lack the power to move the arm, so their active range of motion is lost, but you, the examiner, can still move it. Their passive range of motion is maintained.
But with a frozen shoulder.
With a frozen shoulder, neither the patient nor the examiner can move the joint through a full range. It's locked. Treatment is aggressive physical therapy focusing on ROM exercises, often assisted by intra-articular steroid injections.
Returning to rotator cuff pathology, let's quickly reiterate the distinguishing features of impingement versus a true tear.
Impingement involves pain when the arm is moved through a certain painful arc, as the tendon, usually the supraspinatus, is pinched under the acromion. This is tested using the Neer and Hawkins tests. A true tear is indicated by frank weakness or a positive drop arm test, the inability to slowly and smoothly lower the arm from 90 degrees of abduction.
Now let's talk about a situation that is a true orthopedic and surgical emergency, compartment syndrome. This condition moves quickly and demands immediate recognition.
Compartment syndrome is a life and limb threatening scenario. It occurs when increased pressure builds up in one of the body's confined, non-distensible fascial compartments, most commonly in the lower leg or forearm, usually following major trauma like a high-energy fracture or massive muscle swelling as seen in severe rhabdomyolysis. The high pressure stops blood flow, leading to tissue ischemia.
We rely on the notorious 6 Ps for clinical suspicion.
While often cited, the 6 Ps are not all equally reliable or timely. The most reliable early sign is pain out of proportion to the injury, especially pain that increases when the muscles in the compartment are stretched passively. Paresthesias, or numbness and tingling, is also an early sign of nerve ischemia.
And the late signs.
Pulselessness and paralysis are late, ominous signs that indicate irreversible damage has likely already occurred. You don't want to wait for those.
Given that the clinical exam can be unreliable, what is the definitive quantitative diagnostic step?
The definitive diagnosis requires directly measuring the intracompartmental pressure using a specialized manometer. Diagnosis is confirmed if the pressure is greater than 30 millimeters of mercury, OR, more accurately, if the delta pressure is less than 30.
What's the delta pressure?
That's the diastolic blood pressure minus the compartment pressure. If that difference is less than 30, the perfusion is critically low.
Why is 30 millimeters of mercury the critical cutoff?
That 30 mmHg threshold represents the perfusion pressure necessary to keep muscle and nerve tissue viable. If the pressure inside the compartment approaches the arterial pressure gradient, blood cannot perfuse the tissue and necrosis begins rapidly. The only definitive treatment is an immediate fasciotomy, surgically cutting open the fascia to relieve the pressure. Prognosis drops dramatically after 6 hours of ischemia.
Related to severe muscle injury, we must address rhabdomyolysis.
Rhabdomyolysis is severe muscle cell breakdown caused by crush injury, extreme exertion, toxins, or massive seizures. The key lab finding is a markedly elevated CK, typically greater than 1500, and the clinical hallmark is myoglobinuria dark, tea-colored urine caused by myoglobin flushing through the kidneys.
The urgency here is the risk of kidney failure.
Yes, myoglobin is directly nephrotoxic. The major concern is acute kidney injury, or AKI. Treatment is aggressive 5E fluid resuscitation to rapidly clear the myoglobin from the renal tubules and alkalinize the urine.
Finally, the most common nerve entrapment syndrome, carpal tunnel syndrome.
CTS is median nerve entrapment at the wrist within the carpal tunnel. It's caused by swelling or compression, often related to repetitive use, fluid retention like in pregnancy or hypothyroidism or RA. Symptoms are numbness, pain, and paresthesia in the first 3.5 digits, classically worsening at night or upon waking.
The classic clinical test confirmed the diagnosis.
We use the Phelan test, where wrist flexion reproduces symptoms, and the Tinel sign, where percussion over the median nerve reproduces symptoms. The Durkin test, direct compression over the carpal tunnel, is also highly sensitive. Initial management involves wrist splinting in a neutral position, especially at night. Steroid injections can provide relief, but the definitive treatment for severe or refractory cases is surgical carpal tunnel decompression. Shifting to the lower body, let's start with the hip, where dislocations are a high-energy trauma often linked to car accidents.
The vast majority are posterior hip dislocations, the classic dashboard injury, where the knee strikes the dashboard, driving the femur head backward.
The leg presents in a classic position, shortened, internally rotated, adducted, and flexed. This injury is critical because of two severe risks: a high incidence of sciatic nerve injury and a significant risk of a vascular necrosis of the femoral head if reduction is delayed. Emergent closed reduction is mandatory, ideally within 6 hours.
In the knee, we use specific maneuvers to confirm ligamentous injuries.
For the ACL, the non-contact twisting injury, we use the Lachman test, which is the most sensitive, and the anterior drawer test. For the PCL resulting from a posteriorly directed force, we use the posterior drawer test. For meniscal tears, which cause mechanical symptoms like clicking, catching, or locking, the diagnosis is supported by the McMurray test, which looks for an audible or palpable click during rotation and flexion extension of the knee.
Down at the ankle, Achilles tendon rupture is a sudden debilitating event.
Achilles rupture often occurs during a forceful push-off, presenting with a sudden pop and acute pain. Diagnosis is confirmed by the Thompson test. Squeezing the calf muscle, the gastrocnemius and soleus, fails to produce the expected plantar flexion of the foot, indicating a complete tear.
Let's touch on the popliteal, or Baker, cyst and its confusing presentation.
A Baker cyst is simply an accumulation and extrusion of synovial fluid from the knee joint into the popliteal fossa, the back of the knee, often secondary to chronic arthritis. The cyst can rupture, causing fluid to leak into the calf tissues. This rupture causes acute pain and swelling in the calf, which perfectly mimics a deep vein thrombosis.
A DVT? So how do you tell them apart?
Ultrasound is required to differentiate the fluid-filled cyst from a clot.
Finally, Morton neuroma in the foot.
This is a painful condition caused by degeneration and entrapment of an interdigital nerve, usually between the third and fourth web space. Patients complain of sharp electric pain and often describe a clicking sensation when walking or weight-bearing. It is significantly worsened by restrictive footwear, like high heels, which squeeze the forefoot. These next two conditions represent the most common causes of acute inflammatory monoarthritis after septic arthritis, and their diagnosis rests entirely on a single critical test: polarized light microscopy of joint fluid.
Let's start with gout, caused by uric acid crystals.
Gout causes an exquisitely painful, sudden monoarthritis, classically affecting the first MTP joint of the big toe. That's known as podagra. Risk factors are numerous: male sex, alcohol consumption, a high purine diet, use of loop or thiazide diuretics, and underlying metabolic conditions.
What is the definitive diagnostic signature?
The definitive test is joint fluid aspiration. Gout is diagnosed by the presence of needle-shaped crystals that exhibit negative birefringence under polarized light microscopy. X-rays in late-stage chronic gout show rat bite or punched-out erosions. Importantly, serum uric acid levels are not diagnostic during an acute attack, as they can be transiently normal.
How do we manage the acute attack versus maintenance?
For the acute attack, the first-line treatments are NSAIDs like indomethacin or colchicine. Intra-articular steroids can be used for single joint involvement. For maintenance or prevention, we use xanthine oxidase inhibitors like allopurinol or febuxostat to decrease uric acid production.
Why is it crucial not to start allopurinol during an acute flare?
Starting XOIs during an acute attack causes rapid destabilizing shifts in serum uric acid levels, which can paradoxically prolong or worsen the flare by triggering new crystal deposition. You treat the acute flare, wait for it to settle, and then you initiate maintenance therapy.
Now its counterpart, pseudogout.
Pseudogout is caused by calcium pyrophosphate dihydrate, or CPPD, crystals. It is clinically similar to gout, but typically affects larger joints like the knees and wrists. Risk factors include metabolic disorders such as hyperparathyroidism and hemochromatosis.
What's the definitive difference on microscopy?
Pseudogout fluid analysis reveals rhomboid-shaped crystals that exhibit positive birefringence. On X-ray, the pathognomonic finding is chondrocalcinosis, visible calcification of the joint cartilage. Acute treatment mirrors gout, NSAIDs, colchicine, or intra-articular steroids.
We wrap up our deep dive with the trunk and spine, focusing on low back pain, the single most common musculoskeletal complaint worldwide. The critical first clinical decision is always screening for red flags.
That initial screening is everything. The vast majority of LBP is mechanical and benign, responding to conservative care, and we know that bed rest is generally counterproductive. But red flags demand immediate, definitive investigation with imaging.
What are those flags?
These flags include any constitutional symptoms, like unexplained fever or weight loss, new or progressive sensory or motor deficits, unexplained saddle anesthesia, or bowel bladder dysfunction, which points toward cauda equina syndrome. Also, any history of cancer, IV drug use, or risk factors for compression fracture like prolonged steroid use.
If red flags are absent, the two most common structural causes we differentiate are the herniated disc and spinal stenosis. Let's start with the herniated disc.
A herniated disc occurs when the nucleus pulposus extrudes through a tear in the annulus, most commonly at L5-S1 or L4-L5, compressing the adjacent nerve root. The presentation is classic. Sudden, electric-like low back pain that radiates down the leg in a specific dermatomal pattern, sciatica.
And the symptom that correlates with increased nerve root pressure.
The pain is classically worsened by activities that increase intra-abdominal pressure, coughing, sneezing, or performing the Valsalva maneuver. This happens because increasing pressure in the chest and abdomen translates to increased intrathoracic pressure, which directly pushes on the already compressed nerve root.
Diagnosis and treatment pathway.
The physical exam is key. The positive, passive straight leg raise test reproduces or worsens the sciatic pain. MRI is the preferred imaging modality. Initial treatment is conservative NSAIDs and scheduled physical therapy. Surgery is reserved for patients with clear, progressive focal neurologic deficits, signs of cauda equina syndrome, which is a neurosurgical emergency, or pain refractory to 6 weeks of conservative care.
Now contrast that sharply with spinal stenosis.
Spinal stenosis is the narrowing of the spinal canal, typically due to age-related degenerative changes like facet joint hypertrophy or thickening of the ligamentum flavum. It primarily affects older adults. The resulting syndrome is called neurogenic claudication.
And this gives rise to the famous shopping cart sign. Describe that clinical scene.
The patient experiences low back pain radiating to the buttocks and legs, often bilaterally, which is severely worsened by standing or walking upright, so an extension, and is dramatically, almost immediately relieved by sitting or leaning forward, the position of leaning on a shopping cart or bike handlebars.
Why does leaning forward help so much?
Flexion of the spine, so leaning forward, wires the lumbar spinal canal, relieving the mechanical compression on the nerve roots and easing the pain. This position-dependent pain is the critical differentiator from vascular claudication, which is relieved by rest alone, regardless of position.
What is the treatment pathway for stenosis?
MRI confirms the diagnosis. Initial management is conservative, including NSAIDs, physical therapy focusing on core strength and flexion exercises, and sometimes epidural steroid injections. If the pain remains debilitating and refractory, surgical lamination removing the posterior elements of the vertebra to open the canal is the definitive treatment.
Finally, quickly distinguish between spondylolysis and spondylolisthesis.
Spondylolysis is a defect or stress fracture in the pars interarticularis of the vertebra, often seen in young athletes whose sport involves repetitive extension, like gymnastics. Spondylolisthesis is the subsequent slippage or displacement of one vertebral body over the one below it, typically due to bilateral pars defects or severe degeneration. Both cause back pain exacerbated by extension, and initial treatment focuses on core stabilization and physical therapy.
Okay, let's connect the dots and solidify this complex landscape. We have moved methodically from the high-energy trauma of the scapula and forearm, through the acute septic crises of the joints and bone, and finally into the nuanced chronic battles of rheumatology and spine pathology.
The crucial insight for the learner is recognizing the differentiating factors that are true shortcuts. You must internalize the contrasts. Is the arthritis symmetric, sparing the DIPs, suggesting RA, or asymmetric, targeting the DIPs and PIPs, suggesting OA? Is the spinal pain relieved by activity and worse with rest, like in AS, or is the pain dramatically relieved by leaning forward, as in spinal stenosis? These specific patterns allow you to triage a patient instantly.
We detail the necessary diagnostic steps, confirming that sometimes the simplest thing, like the Finkelstein test or the Thompson test, is high yield, while other times only a specialized study is mandatory. That specialized study might be the immediate delta pressure measurement for compartment syndrome, or the crucial synovial fluid analysis, looking for those negatively birefringent needle-shaped crystals for gout.
And remember the systemic connections, how diseases like SLE rely on a complex constellation of antibodies for diagnosis, or how the simple lab test of a normal CK level alongside a markedly elevated ESR can immediately point you away from a myositis toward polymyalgia rheumatica. Recognizing these key relationships makes this dense material not just manageable, but actionable.
Which leads us to our final provocative thought. We noted how much of our ability to diagnose complex conditions like lupus and the vasculitides is entirely reliant on the presence and titer of specific autoantibodies. We have robust criteria for antibody-positive disease. But consider this. If a patient presents with the clear textbook clinical symptoms, say the heliotrope rash and proximal weakness of dermatomyositis, but repeatedly tests negative for all known classic autoantibodies, what does that mean? Are we defining the disease too narrowly by our current serological technology, or is there an entirely separate antibody-negative pathophysiology that we are routinely overlooking in the complexity of systemic rheumatology? A very interesting question, something to mull over until our next deep dive.